everybody, to this session about palliative surgery. I'm happy to have Geoffrey Dunn by my side, but first I will introduce myself. I'm the head of colorectal surgery at the University Hospital Center at Mainz. I'm a member of the European Society of Coloproctology Research Committee and the chair of the Surgical Working Group for Coloproctology in Germany, the largest group of colorectal surgeons in Germany. My clinical and research focus is on carcinoma and inflammatory bowel diseases, but I have a great interest in palliative procedures and palliative surgery. Regarding my connection to BTS, I have been a member of the BTS Council and the BTS Academy editorial board since 2021, and I have also just been elected vice chair of the BTS Council's executive committee. Jeff and me, we have known each other for 10 years. My goodness, how time flies. Perhaps you could tell us a little bit about your background before we discuss the subject matter, Jeff.
Well, currently I am a retired general surgeon. My background was general surgery, trauma, and specifically burn surgery early on. Then later my career expanded to palliative care and becoming boarded in hospice and palliative medicine, in addition to maintaining my surgical certification. I've been retired now for about 7 years, but still follow with great interest the developments as the field has become much more organized and robust, particularly in the hands of the current generation of surgeons that have a dedicated interest in this.
Thank you very much. It really is an exciting life filled with exploratory and groundbreaking ideas that you are looking over, and activities, a lot of activities that you have brought to life. So let us turn to palliative surgery and address the issue head on. Could you first tell me what is the difference between palliative surgery and surgical palliative care?
It's an important distinction. Palliative surgery is only one of the sort of arrows in the quiver, in the armamentarium of interventions that we have at hand to assist and guide our patients. Those are the techniques, the interventions, whether it's a gastrostomy or a debulking procedure. It's an important and yet a relatively small part of the overall domain of surgical palliative care. Surgical palliative care itself is the attention to suffering in all of its manifestations of patients and their families under surgical care. That would be whether, on the floor, in the operating room, in the ICU, and in the outpatient setting. And for most general surgeons, the most relevant aspects of surgical palliative care are going to be those areas that address communication, because that's an activity that is unavoidable in surgical practice, particularly with respect to disclosure of unwelcome news, and then on the more positive side, skill in prospective planning when facing, the uncertainty that accompanies progressive or end-stage disease.
But when you think back, I'm sure that's really, spoken medicine is really important in that matter, but when you think back, can you recollect what was your first encounter with palliative surgery that had an impact, that made a difference to you?
Actually, for me, as it turned out, I had never really thought about for years whether surgery was palliative or not. I remember the first operations I saw and the first patients I saw, more importantly, the actual patient encounters were patients of my father, who was a general surgeon, and also was the primary role model for my surgical life. He was a great man in war and in peace, and a highly capable surgeon and kind of a giant in our community. And when it became evident that I was kind of interested in a medical career, which was a fairly sudden decision, he allowed me to join him when seeing patients and eventually actually watching the operating room. And the very first patient was an elderly gentleman with a recurrent liposarcoma of the chest wall. And I learned everything I needed to learn about bedside decorum there. You approach the gentleness, the patience, but most importantly, the sense of presence. And I'll never forget the look in the patient's face where, boy, if this guy can't take care of this, nobody can. The sense of calm that came just by the fact the person came in the room and was present to him, and seemed unhurried and not flustered by the task at hand. And it turned out it went well, and he had a fair amount of asymptomatic time after that and died of a unrelated cause. And then shortly on the heels of that he did a bilateral adrenalectomy on a woman. Now remember, this is this is very early 1970s for a woman with widely metastatic breast cancer. And she actually did very well and had dramatic symptom relief from osseous metastases. And I actually got to see her in his office on follow-up. So right there, the very first two procedures they were both strictly palliative, although they weren't really understood as such at that time. It was just part of the surgeon's work. I should mention that at that time, the term palliative surgery actually had an almost pejorative connotation, which created it didn't really help us much that the surgical literature until very recently defined palliative surgery basically as a failed operation. It was like, it was a retrospective definition that defined palliative surgery as, tumor was left behind. There was tumor at the margins, or we couldn't complete we did an operation, but nothing good came of it. And the ridiculousness of that really emphasized itself later during the very last case as a chief resident. Was a woman with bowel obstruction from recurrent ovarian cancer. And I'll never forget at the scrub sink, the surgeon I was working with saying, well, this is an exercise in futility. And which almost always in that era, just about almost always was the case. We didn't have the kind of salvage chemotherapy then. Yeah, unfortunately, we didn't have pegs. We didn't have a lot of things we could do to get out of that situation. And I remember thinking, this is ridiculous. Why are we even doing this? If it's an exercise, why add a fresh surgical incision to all the other problems she's inevitably going to have? And I remember thinking at that time, if there's one thing I change myself as a surgeon in my lifetime as a surgeon, I hope this is one of the first things to go, are situations where we're using surgery for an outcome that we know isn't going to go well. We have to better define our rules of engagement in advanced disease.
Yeah, that is deeply impressive. But you did not proceed directly to palliative surgery, did you? Yeah, I think you rather opted for alternative course of action during your professional life first. What did you do?
Well, I was a very busy trauma surgeon and burns, and I spent some time in India, which was actually my if you were to ask me what was the most important palliative operation I ever did in my life, it was that. That sort of, for me, was the beginning of surgical palliative care as kind of a conscious thought. I saw a young woman who was, it was a homicidal burn, and she was brought into a burn unit that I was just I was invited there to open a burn unit and a trauma unit. And she was brought in, and she had a circumferential chest wall burn and a circumferential neck burn, and was in extremis from respiratory distress. And I did a tracheotomy on her with a pocket knife that I still have, because the trach tray that was presented to me, it had every instrument I needed except a scalpel. And I was able to do cut the cicatrix and do the trach, and immediately her respiratory rate subsided somewhat, and she became more comfortable. She was unsalvageable otherwise because of the systemic problems, and even at that time, even the best, she had like over a 90% body surface area burn. There was even a burn unit that would have had a hard time saving her life. And she subsequently died peacefully, from all the metabolic sequelae of her burn. But it made a profound impression because at that point, it was an intensely opiophobic hot culture for having that recourse. But I realized there were a lot of other things that could be done in terms of attention to spiritual distress and the family's needs. But all the ideas, they didn't come together till sometime later, when I had a personal experience with the loss of my mother from metastatic breast cancer. And during that time, hospice care was just beginning to become organized enough. It was becoming acceptable enough that it was beginning to be much more widely accepted. And that was in the early 1990s. And a year after that, in an unmistakable example of burnout, I stopped my active practice of surgery. And not long after that, as a part-time way to keep my hand in medicine, I worked as a hospice physician at the request of a new hospice in our town. And I was overwhelmed at all the day-to-day problems that were begging for solutions that even the hospice program hadn't quite figured out. Nausea, vomiting, how do you counsel about difficulties in feeding, and what is the role of assisted hydration and nutrition? How do you talk to people about progressive changes? How do you alert them to the expected changes with progressive disease? And after 2 years of that, I was asked by a surgeon to speak to our local American College of Surgeons chapter about my day-to-day work, because a big shot who was supposed to speak canceled at the last minute. And I was seeing a number of the surgeon's patients, things like pancreatic cancer. And then it occurred to me, I think it's time to go to the world of surgery and with some of these ideas. And I met probably one of the most important influences and a dear friend, a guy named Robert Milch, who was only 100 miles away from me in Buffalo. His father was a surgeon too. He was extremely articulate, approachable. He had had almost 20 years of hospice experience. And I don't think I would have been able to go anywhere without his reassurance, his experience and knowledge. And together, we decided to go work with the American College of Surgeons as probably the best way to catch the widest base of practicing surgeons. And it all came to a head in 1997, when at that time, there was a kind of a feverish national debate about physician-assisted suicide. And the college had a long, like a 8-hour symposium, very well attended, about 6 or 8 panelists. And fortunately for us, the person hosting the panel was a man named Tom Krizik, who was a real giant in medical ethics. He chaired the ethics committee. of the college at that time. And we had become acquainted briefly, and he asked me to come out there. So Bob Milch and I went. And just when he said, just show up. He said, you can't be on the panel because it's already set in stone. And then at the end of the afternoon, when I thought I was safely off the hook and wouldn't have to speak or do anything, he said, hey, is Jeff Dunn here? He called me up, and as I'm stepping up to the podium, he said, you got 5 minutes to change surgery. Now don't F it up. So I spoke and I outlined for the assembly. I said, I said, everybody up here, pro and con physician-assisted suicide, they've all said one thing they've all shared. They said the same thing, and that is, we need to do better at palliative care, surgeons. I said, I would tell you, there's a list of day-to-day tasks that we need to focus on. If we do those tasks well enough, the question of physician-assisted suicide will hopefully become irrelevant in most cases. There will be some persistent and serious requests for this kind of assistance. But even when that occurs, we don't even know how to talk about it because we don't know how to talk about death itself or its imminence in many cases. And I went through the list of the day-to-day problems I saw: control of pain, communication, the role of hydration, the role of nutrition. I said, I will do everything I can to help and guide, but I can't do this alone. I'm in a community hospital. I don't have an academic position. But I know all of us today, we definitely can do this. And then there's dead silence, and I was panicked. And then suddenly it was well received. And right afterwards, it was the most senior and well-known surgeons in the God that came up first and said, we have to do this, and we'll do everything we can to support you with it. And they were as good as their word. They did, in terms of getting on committees, invitations for publishing. So the whole thing started actually with what I thought was a pretty sterile and not very helpful clinical debate about physician-assisted suicide. And this is a recurrent question in medicine. And now, and during that year, there were several Supreme Court decisions that were addressing that issue. But what was helpful in the decisions was the court opinions identified palliative care as a legitimate and valuable adjunct to care for our patients, at least in the U.S. UK was way ahead of us in terms of organized palliative care. They had certification, they had program fellowship long before we did. It wasn't until the early 1990s that we had anything close to that in the U.S. And then finally, we did have hospice and palliative care certification around 2008, and I'm proud of the fact that surgery was one of the boards that signed on for that.
Yeah.
That's it in a nutshell.
That is really touching and impressive. And what do you think, from a cultural background, what influenced yourself in the formulation of surgical philosophy? What was that really made an analytics background?
Well, that's I like the question about philosophy, because I never thought of surgical philosophy until I had a terrific mentor as a resident. And interestingly, he was a big mentor of Tom Miner, who will be presenting in this series. Both of us are much in his debt. He was a real giant in surgical oncology. He edited all kinds of journals, clinics in North America, and he gave me my first opportunity of publishing this in 2001. His name was Blake Cady. And one time during an M&M conference, they were discussing following CEAs, following colonic resection for carcinoma. And there was a lot of back and forth and disagreement. He was somewhat skeptical about the practice at that time. And he said, we got to take a step back. He said, it's a lot easier to make the day-to-day decisions in surgery if you have an overall surgical philosophy. And I thought, wow, this is really cool, because he was undoubtedly an intellectual, but this was a guy who was not only an intellectual, but was a superb operative surgeon and a superb thinker. So being a little bit of an egghead myself, I thought, boy, it's nice to know that you can be intellectual and be a hardcore surgeon. So that really got my attention. And that was the first time the first sort of building block in my own development of thought about this, that it's really helpful to have an overall philosophical framework as you work on the details and plug in things like, well, what is palliative surgery? How do you do it? How do you measure it? How do you know if it works? And so on. And that was only one of the pieces. So it's wonderful that both I and Tom Miner are participating in this, because we were both impacted by this real giant in surgery.
What impresses me really about the stories you are telling is that when you were going into the field of palliative care, let's say, not palliative surgery, you recognized this huge lack of palliative surgery. But what made you believe that surgeons were capable of providing palliative care? That was groundbreaking at that time.
Well, you already put your finger on it. You said it's that ability to make a decision, and I would append to that with limited information, often with limited information, in even more limited time. When the emotional temperature on both sides is very, very high. And I thought, I think we are really good at crisis management. We are really good at compartmentalizing. We like steadiness of temperament. We admire that in the people that trained us. If we can learn a little bit about some of the details, we can be effective. And I couldn't have had two better role models. I thought, God, Bob Milch here's an example. Here's a handsome, articulate, gentle person who was a superlative general surgeon. He had a giant practice, and I had such admiration that he believed so strongly he could make a difference in the then new field of hospice. This is 1978. I admired that he had the courage to walk away from that practice, go into that, and then he kind of resurfaced, in the surgical world with surgical palliative care. So I knew it was possible, and I had my own father, and my father was not a touchy-feely type of person, but he did project a sense of presence. And all you have to think about is that the core moral principle of surgery, I believe, is non-abandonment. And there's a way of projecting that. And the fact that we were always proud of the fact as surgeons that we were sort of the last chance cafe. If there was a mess that came into the emergency room, the last people to get turned to when no one could sort it out, hemorrhagic pancreatitis, disasters like that, one way or a bad burn, even if surgery might not be anticipated, surgeons were proud of the fact that they would be called upon for the most difficult of clinical problems. So I had no doubt in my mind the surgical temperament would adapt to it. With respect to communication, surgeons sometimes often get bad press that they're not great bedside manner, they're not great communicators. I thought, okay, if we put the discussion about disclosure of bad news in a language or in a format that surgeons can understand, maybe they'll do it well. And the format for surgeons was disclosure of bad news. It's like it is an invasive procedure. You need to be prepared. You need to be gentle. You need the permission of the person receiving the news. You need the go-ahead from them. It's wise to have an assistant with you. You have to assess the impact of each move you make, just as you do when you clamp a major vessel. You got to say, well, what was the hemodynamic consequence of this, or any point of no return move in a procedure. To me, this was doing an operation. And I thought if surgeons understand this procedure this way, they're going to be much more at home with it. They're going to be much more care. And there's aftercare after you disclose bad news. You don't just get up and walk away. And you do a post-op check. You check on someone later on. How are things going? Have you given more thought, or have you given more questions, or how are you doing in light of this information that you just received today? So I think every aspect of what had been identified by the forerunners in hospice care and then later palliative care is completely adaptable to surgery. And I think when surgeons do get it, I'm being a chauvinist now, I think we do it better than anybody.
That's a typical surgical answer.
Shameless.
No, but I think you mentioned, and I think that's really, you need like a moral frame or a surgical philosophy to be convinced that you're acting in a certain justified frame and that you are right. And of course, it's helpful to have role models, but you have to have an inner convincement of what you are doing. But I could guess there were also people who were not so open and willing. And what were the obstacles to the acceptance of palliative care? I mean, what were the arguments in the surgical community against it?
Well, a lot of it was just misinformation, which is why in our really early days, we really wanted to get working on that as quickly as possible. And one of the first things we did as a group was we put out a series of monthly articles in the Journal of the American College of Surgeons. Once again, we had a wonderful tailwind because the executive director at that time, or the editor, was a woman named Wendy Husser, who, because of experiences she had in her family and her thorough knowledge of surgery, this is the only person that has read cover to cover every edition of Schwartz's Principles of Surgery, right up through like the 10th or 11th, because she was the editor for that textbook, and she knew everybody who was anybody, at least in American surgery. So, but she felt very strongly about this right in the beginning. So she, with Dr. Schwartz's blessing, allowed this series to be published. We thought it was only going to be a couple articles. It went on for almost 4 years, monthly articles about all the aspects, all the day-to-day problems of palliative care and surgery.
And then so that's how the concept
of
education,
because in the beginning there was a lot of misunderstanding. There were a lot of people, not just the public, but physicians, surgeons, our referring doctors, that thought, it was homicide to discontinue life support. And early on, if you talked about palliative care, many surgeons had the reaction, oh, I have a friend who's really interested in ethics. They thought it was just about ethics. Like there wasn't, ethics didn't come up anywhere else, just where it got in your end of life where you might be killing somebody. So early on, a lot of the people that were really interested in this were people that were already interested in the field of medical ethics. And although that was an important part of surgical palliative care, they weren't interchangeable. In my own hospital, for example, we had an ethics committee. And in the late 90s, I realized, most of the referrals we're getting are these are not ethical questions. You know, rapidly escalating doses of opioids for intractable cancer pain is not an ethical dilemma. It's a practice competence problem. So that was the beginning of a palliative care consultation service. I said we need a clinical arm of the ethics committee to nip these referrals in the bud and start taking care of patients again, and not drift away into some of the intellectual arguments like physician-assisted suicide, which had a disproportionate dominance over the discourse of our field in the early days, and thankfully we've kind of gotten away from that.
Yeah. But when we come to the questions that still concern palliative surgery, and it is also about dying, do you think is the prognosis relevant for the indication for palliative surgery, or is estimated survival relevant? And if so, what would you think to be a cutoff? What are you measuring there?
Well, the prognosis or the estimated survival is very relevant if you're talking about imminent demise. And I only mention that because one of the early things that we realized surgeons needed education about, along with our physician colleagues, was I was struck by how many surgeons and physicians didn't recognize the syndrome of imminent demise. Whenever this was apparent on rounds, it was always attributed to, polypharmacy drug delirium, or delirium resulting from organ failure, bad clearances, renal failure, hepatic, that type of thing. But I noticed it was never on anyone's differential. This person's actively dying. They're showing all, and the being able to distinguish these two is critically important, because the management is so different for these things. So, we got to be able to do that before we make decisions about, well, are we going to do anything invasive, in the next few days, even if it's even something as simple as limited endoscopic procedure. I think Tom Miner will be able to better address where's the discussion now in terms of timelines. Where's the research telling us at what point does a given procedure show any benefit? One thing that he was able to demonstrate is that the cost, the penalty for a failed palliative operation in someone identified as having advanced is very, very high in terms of hospitalization, added morbidity, and shortened life. So he's saying, don't be hesitant about taking aim and doing one of these things, but boy, your aim better be very good. You need very good prognostic. And we now have assessment tools in this equipment. We have a lot of data, and AI will probably help with this, along with a lot of other things in terms of better assessing prognosis and knowing, how sensible. It's an important factor, but it's such a moving target because people are so different. I had a patient once, it was a young woman, had a pathological femoral fracture. She was already a hospice patient, and she just had agonizing pain with any movement, including her dog jumping on her bed and her 7-year-old and her 4-year-old children. And we just could not get her comfortable. Her incident pain was off the charts, and even at rest, could not get her comfortable. She had some degree of preservation of muscle mass and no other serious imminent life-limiting comorbidities. So I called our hospital, an orthopedic surgeon who I knew was extremely expeditious in his work. I called an anesthesiologist who was not going to be chicken about, needing, needing to drag someone through the medical home for 2 months before they could put the person to sleep. We brought her in. They did her under spinal. He did a fixation of the fracture. We brought her home the same day with the epidural catheter in place for ongoing pain management. And it was wonderful. She was comfortable. She actually had several weeks after that. But that was having the right people at the right time. That was having every tailwind. If any one of those pieces had been missing, it may not have been such a good idea. It might have made the situation even worse than it already was. But it shows you how specific these decisions can be.
Yes, and that touches on
individualized, I should say, not just but individualized.
Yeah, and it touches also my next question, because you touched it before about the timing of the definition of a surgical procedure. So when we now imagine a palliative procedures in the everyday life of a surgeon, even if this everyday surgeon is not calling him or herself a palliative surgeon, what do you think is palliative surgery defined before? Is its intent the definition of palliative surgery, or is it defined after a surgical intervention as having been palliative?
The afterwards definition harkens back to the old days where it was retrospective, but I think everyone agrees now the gold standard for measuring outcome is it's based on shared decision making. And the measurement of success is, well, how well did we measure up? Or what's, and we have a lot of scales now that give the patient and then even their family the means to tell us, well, how well did we address that symptom? And a lot of work has been done with this by Tom Miner. Robert Krause at Penn is, along with Tom, has done work for years in trying to define what palliative surgery is, what the rules of engagement are. And Robert Krause took on what was always sort of the poster child for palliative surgery, which is relief of malignant obstruction. After all, that was the first successful abdominal operation, at least for gastric cancer, was a palliative operation. It was an obstructing carcinoma of the pylorus that Billroth resected in 1881, and for someone who had a disease advanced enough, he could palpate the tumor on exam, and it relieved her of intractable vomiting, and she succumbed several months later from metastatic liver disease. So that was always kind of the poster child for palliative. But when we looked at malignant obstruction, which we've been looking at since the Jack series in the early 2000s, we realized what a complicated field. There's so many types of obstructions, and we do have more tools at our disposal to handle this. When we first started looking at this, PEG wasn't in really wide use wasn't an option that was widely used for relief of malignant obstruction. And we had to do the best we could with pharmacologic management, anti-secretory agents, anti-peristaltic agents, opioids, haloperidol for nausea. It was sort of a cocktail of those things. If you had someone who was clearly non-operable, that was the best we could do for malignant obstruction.
Yeah, and
so it's just defining the problem itself has taken years for them to do before they could really start, prospective clinical trials. And Tom can speak much more authoritatively about that than I.
As you just mentioned, the word of success, and I mean, surgical successes, there are different definitions of surgical success. We usually measure postoperative morbidity and mortality. They are the mostly used outcome measurements in surgical procedures, but understandingly, they have much less meaning in palliative patients. So how do you define?
Yes and no. Yes and no. You don't want the person who's dying of a cancer to die from your procedure. And the worst operative complication you can have is in a person where the only purpose of the operation was palliation of symptoms. My father used to make this comment about an ill-advised procedure that was meant to palliate someone, and it just made everything worse. He said, he said, if you're going to palliate someone's surgery, you damn well better palliate them. You better be sure you're agreed about what distressing symptom you're having, explain how the procedure is actually going to do that, and then the procedure better do that. And that was kind of the metric. That's the most basic, crude metric of how to measure success. So the morbidity and mortality following that is very important. Another important related idea that I'm thinking of all the people I want to thank and acknowledge in the time I have to speak. There's a Norwegian, I would say he and his colleague, they're pioneers of surgical palliative care in Norway. And they all, the two of them, they kind of figure out all the nuts and bolts just in their own very busy clinical experience in Stavanger in Norway. And in fact, they wrote a paper, and I believe it was in BJS, where they were discussing, his name is Jan Arne Søreide and Hartvig Kerner, and you might know Hartvig. They made the point in the article that you don't do an intervention, you don't do an operative intervention, even in the name of palliation, simply because you feel helpless or the patient feels helpless or abandoned if you don't do it. You do the procedure because you believe this procedure will help the agreed upon symptom of note for relief of it. And I think that's a really important, because there's always that feeling like we've got to do something. We got to do it. And sometimes the best thing, the most helpful thing you can do as a surgeon is to do nothing. In fact, probably more often than not, especially in people with very advanced disease, in the ICU setting. And those are the patients in the last 5 years of my practice. Really, all the patients, they were all ICU patients. Half of them were trauma patients, and the other half were, end stage, just about everything.
Yeah, but doing nothing sometimes asks for more surgical maturity than trying to show action, in my experience.
Which is why, the older surgeons have much to contribute. I now that I'm into my 70s, I think older people do have much to contribute. I think of people that have shaped my own worldview, my Weltanschauung, my outlook, not just in medicine, surgery, but in life itself. I have my personal cabinet of older men. And if anyone asks me, do you have any advice for young surgeons? I would say yes. Find someone significantly older than yourself, someone smarter than you, more accomplished in something than you, and stick to them like glue. I have 4. I'm really lucky. One of them is a legendary surgeon who I'm sure you've heard of, Gerald Marks. Jerry is 100 years old. Jerry is also an artist, and I'll come back to that. Another is an art gallery owner. The other is a artist who's 92 years old and works diligently. If you walk into his studio, you'd think you're walking into an operating room in terms of the seriousness of purpose and the instrumentation and everything, and the work ethic.
May I come back to the book that this really profound book of palliative surgery? And you wrote in that book that success is measured in procedural outcomes rather than patient-oriented outcomes. That was a quotation. And I think nowadays patient-reported outcome measuring with a focus on functional results is increasingly accepted as a core surgical quality control, and I'm convinced of that. Do you think that will have an influence of the acceptance on the acceptance of palliative surgery? So are these two sides of the same coin, the quality of life and the quality of dying? Do you think that?
Boy, quality, I guess my question is, where does quality of life and quality of dying, where do they meet? I sense them as a much more of a quantum, if you will, continuum, not something that's that compartmentalized. I think one of the biggest changes, I think, in medicine in general, since early 1980s, has been the shift in the most fundamental changes, not only the availability of information, but the balance of power between the physician or surgeon and the patient family. And with that shift, where it's much more patient-centered and focused than it was 40 years ago, I think that's only enhanced the validity of the patient-defined parameters for success of a procedure than would have been, 40 years ago, where, well, I know what's best for me, sort of that attitude. Because 40 years ago, it would have been much more about, if people were thinking about specific palliative surgery, they were still probably thinking more about survival than relief of symptoms. And now, fortunately, in the meantime, we've learned a lot more about how you do relieve symptoms, even if surgery can't address all of them. And an important part of the negotiation of palliative surgery is competence in managing the inevitably concurrent symptoms, because you rarely have anyone who's there where there may be an indication for a palliative surgical intervention who doesn't have at least 3 or 4 other pressing, bothersome symptoms. And sometimes those could get even worse with the intervention. But you don't go into this alone as a surgeon. You have to cultivate the habit of group thinking, cooperation and respect for not just your colleagues in medicine, but your social worker, whoever's been entrusted or acknowledged as providing spiritual support or care for. All of these are important support avenues of support in dimensions that have to be considered in the not only the framing, but the actual guidance of any operative intervention. You have to have the mindset that realizes that these things also matter, and these are ultimately, if you're skillful enough in being your corner of the palliative triangle, you're in the physician corner, you're going to be very open to the input and the voices of some of the representatives of some of these other issues, whether it's, skill in pharmacology. And I've always emphasized in teaching surgeons, one of the first things you want to do, if you want to become really engaged with this, like starting a palliative care service in your hospital, one of the very first things you need to do is to identify a PharmD that you're going to be working with. They're going to be your best friend, and the next person you're going to want to find is a skillful case manager who can, help you with the transitions, because a lot of the most bitter complaints and some of the worst disasters I've seen have been, transitions in care.
When you wrap up all together what you just mentioned, what is your personal definition of a good death?
Boy, well, my definition may not fit anybody else's.
Oh,
It's
no.
personal thing. What I can tell you is when this has been studied, there's generally been agreement that, good symptom control of symptoms identified by the patient is very important to the patients themselves. It's also important to the family. In some studies, even more important to the family than the patient. I think preserving a sense of dignity, and that's a little tricky because that may be defined very differently from culture to culture, but every culture, I'm sure, has its own very clear understanding of what that represents. So it's a question that always has to be asked or thought about in the discussion. It's a good question in prospective planning and trying to decide, well, what has to be provided for, what has to be planned for. So I think it's a useful question, but the answer is very personal. There's no cookie cutter. One of the early problems hospice had was it was conceptualized and it was first endorsed and accepted by people that were comparatively well educated, well means, and they had an understanding and they had the means for a different type of death than a lot of people would be capable of, or that a lot of cultures would even accept. Not every culture thinks that it's a good idea to have mom pass away in the living room. There's some place where that might be taboo. That's going to invite ghosts or some kind of ill will, or it's just a taboo. So I think we learn that we can't project whatever our prevailing cultural view about what a good death is when we're now increasingly in a world that has diverse backgrounds and cultures. The only way you're really going to know that if you're going to be part of the group that's intervening in any way is to ask, is to find out.
Thank you very much for this really helpful and thoughtful answer. So now at this juncture, having considered the past developments and obstacles and the current implementation of palliative surgery, the question must be posed, what do you think are still unsolved problems in palliative surgery, and what would be your wish for the future development of surgical palliative care?
Well, an early wish I had, and one that I continue to have, is that there will be a complete seamless blending of the framework that I've talked about and written about in surgical palliative care and surgical practice in general, where we're not even conscious of so much of, we know that there's specific chapters in life, but basically the way we conduct ourselves, the way we measure ourselves and our outcomes, the way we interact with patients, the way we assess data, it's going to be the same for any situation that we traditionally have identified as being suitable for palliative care or hospice care. It's the same as it would be at the front end in pediatric care, any care. And my observation has been surgeons that have been at the very top, in my estimation, have been able to move from those different chapters without really changing their personality, their attitude, or the gratification of their patients. I think we are going, as surgeons, we're going to be facing an identity crisis as the repertoire of surgery is increasingly replacing itself. I mean, when I started surgery, the repertoire really hadn't changed that much, from the 1930s or even earlier. There were a few additions, but they were usually highly specialized, things like transplant. But now, I can't think of anything that I was doing in 1984 when I started practice. And when I stopped my medical career, virtually it was like a total exchange transfusion. But that exchanging is happening faster and faster, and more of it will be replaced by robots. So where is our sense of meaning? How do we satisfy whatever inner need we might have for a meaningful experience, even a spiritual experience, which I think it ultimately comes down to for a lasting sense of satisfaction, even when we're not directly involved with it anymore. So that's a future challenge. Burnout's already been pretty well identified, and I do have one suggestion for burnout, which is, and we can go back to Bill Roth to get a sense of direction for this. Someone had asked him about the conflict or the divide between science and the arts, and his response was, this was sort of silly that there was this differentiation. He said his words were, they both dip from the same well. Both science and artistic endeavor are products of the human imagination. And Einstein said something similar. And I think we can look to the arts and expressive arts as potential avenues for the mitigation of burnout, but it gets even better than that. I've been a pretty serious landscape painter. Now I'm full-time painter. I and Jerry Marks, who I mentioned earlier, we both realized that our life as painters, it's exactly the way we felt during our lives as surgeons. We're using instruments, we have our eyes focused on the target, and when we're engaged in our subject of whether it was operating or painting or drawing, the rest of the world didn't exist. When I painting or when I was operating, I was so focused on what I was doing. Someone could drop a tray of instruments or a bomb could go off behind me, and I wouldn't even notice it until it was, I was over, done with the procedure. So we realized, well, for surgery, surgery is actually not only a visual art in terms of we're creating objects of beauty, but it's also a performing art in terms of how do we conduct ourselves. You're a real artist as a surgeon if you perform something expeditiously, flawlessly, and to an observer, it looks easy, graceful. It's a joy to watch. So we realized there was so much overlap that we thought some experience, at least in expressive art, representational activity like drawing, painting, where we're using many of the same faculties in terms of spatial recognition and spatial awareness, situational awareness, would be very helpful in the formation of and the ongoing guidance for surgeons. We'd like to, we've formed a group of, we have about 30 surgeons interested, and we're building a website. We have now the Surgeon Artists League, and we're welcoming interested people to promote this idea because it's a great joy, and you don't have to worry about hurting anybody or getting sued or anything like that. But when you're doing, you suddenly realize, oh my gosh, I have that same wonderful feeling as a person of action, using their hands, cultivating skills. I have that in drawing or painting, just as I did in the operating room. So something fun, something to consider.
Thank you very much. I think you are really a being that is inherently inclined to take action. And I was sure there was something about your forthcoming personal projects that you just mentioned. Thank you for that. And thank you very much for the comprehensive overview and the in-depth insight into palliative surgery. the time that was dedicated to this endeavor from your side, as well as the willingness to discuss the subject and personal experiences. It is deeply appreciated from my side, but I'm absolutely convinced also from the audience that will listen and really enjoy what you explained here. Thank you very much.
I would like to finish with I'd like to read this is a passage from a letter that was written to me. And I want to read it because I think it expresses the very heart of what I alluded to earlier, the spirit of non-abandonment and presence. This was written by a surgeon. He's an ophthalmic surgeon still living, F. Harold Kushner. He was the only physician who was a prisoner of war during the Vietnam War. He was gravely injured in a shot down helicopter and was a prisoner of war in the jungles before he was in the prisons of Hanoi for some 6 or 7 years. He wrote, quote, "As a young military flight surgeon in the 60s and 70s, unfortunately, I spent almost 6 years as a POW of the Viet Cong, first in the jungles of Vietnam and then in the notorious prisons of Hanoi. I had no medicine or instruments and could only palliate the dying prisoners by simply holding them in my arms. 12 died that way, 10 Americans, 2 West German nurses mistakenly captured. I hope that I was able to ease their suffering and help them to the other side." Thank you.
Thank you very much.